So welcome everyone. We are delighted to have Professor or Dr. Juan Carlos Velez here from Ochsner, New Orleans, who will be presenting to us on hepatorenal syndrome. Dr. Velez earned a medical degree from Peru, and then he did residency in Chicago, and followed by a clinical fellowship in Emory. He was briefly at the Medical University of South Carolina, and then for 11 years actually, and then he moved to be chair at Ochsner Health in 2016, where he's the section chief. He has done research in the intraglomerular RAS system, but then he's transitioned on to hepatorenal syndrome. And these days, of course, he's way more famous for his urine analysis pictures that he posts on social media. We'll be having another talk by him on Friday morning, which will be on urine analysis. So with that, I'll give it over to JC. I'm just going to start sharing his actual presentation. I hope everyone can see the presentation, and over to you, JC.
Thank you. Thank you, Swab. Thank you very much. I'm really excited to finally come to Ottawa after Swab and I planned this visit for a while. So this presentation, where I'll be sharing with you sort of the path that we go through when we encounter a patient with acute kidney injury and cirrhosis, and we suspect hepatorenal syndrome as a diagnosis, and some of the challenges that we face, and touch on the treatment options that we have. This is my disclosure pertinent to this talk. My relationship with Molecule Pharmaceutical, which is the maker of terlipressin. We will discuss some of the data without the indication this morning. So let me start with the case, just to give some framework. A 53-year-old patient with cirrhosis due to alcohol dependence arrives to the hospital, has a baseline creatinine of 0.9, and is admitted due to worsening jaundice. There was no history of diarrhea. Patient was not on diuretics, not on laxatives, only on Nadolol for prevention of variceal bleeding. On arrival, the blood pressure is 115 over 55 with a MAP of 75, saturating 94% on room air. On examination, tense ascites, jaundice, 2+ peripheral edema. Creatinine is now 2.4, bilirubin is 13, urinary sodium was less than 20 at that time. Urine microscopy was performed and showed bilirubin stain high in CAS. So we have a history of a patient with counts with alcoholic cirrhosis and an AKI without a clear cause, not much of a volume depletion history. So we're starting to suspect HRS. Which of the following next step will be the most appropriate? Should we get a FENA to calculate fraction excretion? Should we just give albumin, or should we use mitonin and octreotide, the famous cocktail of HRS, and go from there? So let me just start my talk on HRS always with this seminal report by Solomon Papper, and really a fantastic paper. 1959, 22 patients with cirrhosis were admitted to the hospital for various reasons, but ultimately all of them developed acute kidney injury, which was characterized in this manuscript as having creatinine between 2 to 7, and the urine microscopy actually described as bland at times, but occasional granular CAS were also present. But what was common about all those patients that they ended up dying with hepatic coma, and 18 out of the 22 underwent autopsy. And to the surprise of the physicians at the time, the tissue was, the parenchymal, kidney parenchyma was essentially normal with minimal tubular flattening and some bile staining, which was sort of the beginning of recognition of a condition that have a major discrepancy within a functional failure of the kidneys and a relatively preserved renal parenchyma. A couple of decades later, this report from a Danish group, one of the first demonstrations of actual reduction of renal blood flow in patients with cirrhosis. This is actually a puncturing of the femoral artery to measure renal blood flow by the xenon washout technique. Not a very popular technique these days, very invasive. But they were able to look at renal blood flow measurements in a group of patients going from controls from the right to cirrhotics, cirrhotics with ascites, with azotemia, and all the way to the left with isotemia, and oliguria, you can see a progressive decline in renal blood flow in those individuals with cirrhosis and AKI. So we're not going to spend a lot of time on pathogenesis. I would like to jump to the bedside issues, but just to summarize here, what is the current understanding of why we think this renal hyperperfusion occurs in cirrhosis starts with intrahepatic vascular resistance that comes with a stiff liver, and that leads to sort of a maladaptive extrahepatic vasodilation led by nitric oxide, primarily in mesenteric vessels. It causes splenic arterial vasodilation. We also know that there's a gut bacterial translocation in cirrhosis that leads to endotoxin release, which further amplifies nitric oxide release and splenic arterial vasodilation. We also know that as a response to this cirrhotic state, there is release of growth factors that will lead to development of poor systemic shunting. And all those mechanisms ultimately lead to a fall in the effective arterial blood volume, and that causes sort of a response in increase of cardiac output. But ultimately, the fall in systemic vascular resistance leads to a defective arterial blood volume. And this is sensed by baroreceptors, stretch receptors, some of them in the carotid sinus. They're going to signal to the brain to say, okay, something is wrong. We need to really restore perfusion. And they do so by activating the renal sympathetic nervous system through catecholamines, primarily norepinephrine. And that is going to locally cause renal vasoconstriction in addition to the systemic effects. We also have baroreceptor stretch mechanisms at the glomerular afferent arteriole that also activate a local renal sympathetic nervous system and more amplification on the norepinephrine effects. We also know that catecholamines through beta receptors activate renin-angiotensin system, and so do prostaglandins. And ultimately, that's going to lead to angiotensin 2 activation and more renal vasoconstriction. We also know that something that occurs in parallel to these processes, some work actually kind of came from a lab in Canada, that is the hepatorenal reflex. Essentially, hepatic sympathetic nervous system is activated due to the increased pressure in the hepatic sinusoids, and that leads to a direct activation of renal sympathetic nervous system independent of the systemic effect. It's called the hepatorenal reflex, which further activates and causes renal vasoconstriction. So it's that's sort of the main understanding we have today. Well, let's go back to the sort of the clinical dilemma. You have seen a multiple or have access to reviews where they talk about the differential diagnosis of AKI and cirrhosis, sort of a three-way split. Either you have renal, you have ATN, you have HRS, and we have to decipher where does the patient belong. But in practice, it's perhaps a little bit more complex. First of all, the notion of acknowledging that there is overlap, and sometimes there's not quite a clear cut between some of these diagnoses. And it's also important that we have recognized over the last 10 to 20 years sort of clinical syndromes that are unique and not quite those three, such as abdominal compartment syndrome, cardiorenal syndrome in the context of cirrhosis. And then you have the sort of the other causes of AKI, such as acute glomerulonephritis, acute interstitial nephritis, and obstructive uropathy that could also be present, and we have to also consider them when they come when take these patients. And finally, the possibility that some of these patients have underlying chronic kidney disease has increased with the sort of increase in the prevalence of fatty liver disease and metabolic syndrome and diabetes. We see more CKD and cirrhosis at baseline, which creates another confounder. Now, what we have been using as a guideline to help us navigate this diagnostic dilemma in cirrhosis and AKI has been the International Club of Ascites criteria. And this criteria, the latest iteration in 2015, was originally described in the 90s, essentially says if a patient is unresponsive to AKI, to volume, then you got to consider HRS, and you have to rule out certain things. So first of all, you have to use the KDIGO AKI definition, which is probably a good decision by this club, because in the past they required a creatinine had to be greater than 2.5 milligrams per deciliter, which we know is obsolete to use that these days. But let's go about the other elements of the definition. You got shock. The problem is that defining shock is quite arbitrary in this setting. Sometimes patients arrive to the hospital with a blood pressure of 85 or 45 with a MAP of 58, and some physicians may perceive the patient is a while awake talking to you. That's just a baseline cirrhotic blood pressure, and then they don't consider shock, where the next physician may say, oh, this is shock. Let's put this patient in the ICU and then start a pressor. So you see there's a variability. There's not quite an objective definition of shock. Hematuria said if the criteria said that if you have greater than 50 RBCs per high power field, that cannot be HRS. But what does that mean? If you have 10 to 50 is okay. Or if you have a Foley catheter, that doesn't matter. What if you have IgAs in the background? The most common secondary cause of IgA nephropathy is cirrhosis. So a lot of these patients walk around with chronic hematuria. How do you interpret that? What about in morphology RBC? So it's really not a very helpful criterion. Then you have proteinuria has to be greater than 500 milligrams per day. Well, first of all, we don't really measure 24-hour protein in the context of AKI, particularly if they're oliguric. We kind of use UPCR, which are also limited. So we go by the dipstick. So it's really not, it's a little problematic to just follow this recommendation. They also call for abnormal kidney ultrasound. Well, in this context of having patients with ascites, it's very common to have a column of fluid that will make the kidneys look hyperechogenic at baseline. So I'm very rarely certain if the renal ultrasound is normal or not. We can't really tell. And they say you cannot be a nephrotoxin, and that's literally impossible in the context of hospitalized patients that come with an infection, receive antibiotics. So a lot of these patients are going to be treated with some medication that has the potential to be nephrotoxic, and short of a kidney biopsy, we cannot really be absolutely certain that those drugs play a role. Recently, there has been a push to bring back the fractional excretion of urinary sodium or the urinary sodium back into the definition, because the earlier definition in the late 90s required a urinary sodium less than 10, but then it was removed from the definition because of the perception that you may have HRS with urinary sodium greater than 20, which I don't agree. So there was a push to bring it back, and they call it, well, maybe it has to be very, very low or less than 0.2%. Well, if Eufina is 0.2 to 0.6, are we still going to rule it out completely? What about ANGAL as a biomarker? We just don't have the data yet for clinical use. So you can see that this is not a quick checklist, checkbox that we can come up with a diagnosis. But as I said, before we get to that, what the criteria calls for is to determine if the patient responds to volume. So essentially give volume to the patient for a couple of days, stop diuretics, give albumin, and then come back 2 days later. If they're not get better, then we'll see what it is. And first, it's important to mention that there is a rationale for albumin. Why not just saline, for instance? We have some studies in cirrhosis where albumin has demonstrated to be better volume expander. This is in the context of prevention of post-paracentesis circulatory dysfunction, a small trial of around 70 patients in Spain that show that if you give albumin versus compared to saline in a large volume paracentesis, you're less likely to stimulate plasma renin activity. That is the way this hemodynamic derangement is defined. And subsequently, in 1999, this very highly cited study, also from the Barcelona group, showed that the combination of albumin and antibiotic was superior to the combination of placebo and antibiotic in prevention of post-spontaneous bacterial peritonitis, AKI, which was functional in nature. So essentially, you can prevent HRS by giving albumin. So those are just two studies. There are some other smaller studies to mention, but in general, it's pretty reasonable to conclude that albumin is a better expander. So if you're going to give volume, albumin seems to be the right option. Question becomes, should we just give it to everybody? We have begun to understand that albumin is not necessarily as safe as we thought. This is a paper that was published not too many years, a couple of years ago, the entire trial, a randomized trial that tested the hypothesis that if you give albumin to normalize the albumin to all the cirrhotics, we're going to save lives. Bottom line is that we didn't save lives, but what we showed is that patients that receive albumin, you can see in this graph, the albumin levels went up. But importantly, there was an increased risk for pulmonary edema full overload from 2 to 6%. So that was an important learning from this study. Prior to that, when I was still at the Medical University of South Carolina, I worked with a couple of my colleagues, Nathan Kirkall and Terrence Huggins, and we were starting to explore the utilization of point-of-care ultrasound in the assessment of volume patients with HRS. This is a study of 52 patients in the hospital who have deemed to be euvolemic by the primary team, diagnosed with HRS. We wanted to see what was the volume status about those patients using IVC diameter and collapsibility. And essentially, we found out that there was also sort of a three-way split. About a third of the patients were still volume depleted despite being in the hospital for 3 to 5 days. A third of the patients were actually volume overloaded with not fixed, dilated, non-collapsible IVC and evidence of intraglomerular hypertension as well. And then about a third were actually considered technically euvolemic or considered by HRS. And about a quarter of these patients got better with either more albumin or with diuretics or paracentesis. So that kind of opened our eyes in terms of this notion that every patient should receive a challenge of albumin when they come. But once we go through that phase, okay, we decided that the patient needed or didn't need albumin and the patient didn't get better. Now we have to establish a diagnosis. So why is that it's so important that we define HRS, right? We're essentially trying to distinguish it from other causes. And the reason is because it's very unique. We have a specific treatment that we were to apply to any other form of AKI is not going to necessarily lead to an improvement in kidney function. And we are challenged to do that by using this criteria to distinguish HRS from other causes, and is it really achievable? And I show you some of the limitations of those criteria earlier in the slide. And just to touch a little bit more on the fractional excretion of urinary sodium, I love physiology. I have to talk about urinary sodium a little bit, and it's sort of a good and bad about this marker. So here is one of my favorite studies on this topic by Hani Vadeh at Jacksonville, Florida. And this is a study with 88 patients who underwent kidney biopsy because they were trying to determine if the patients were going to receive a liver transplantation alone versus a liver transplant and a kidney transplant at the same time. So they had actually biopsy diagnosis, and 10 of these patients had normal parenchyma. So they were diagnosed as HRS by biopsy, which is very unusual. And in this study, you can see that the fraction of excretion of urinary sodium was extremely low. Everybody was less than 1%. So less than 1%, it just doesn't help you distinguish any of the causes. But it was noted that they were very low. There was still overlap, but that was an interesting observation. And it was actually interesting to see around the same time, Justin Belcher at Yale, using the Tri-AKI Consortium data, found something quite similar, where the patients with HRS in green had fractional excretion of sodium 0.3% or less. So starting to come with this signal that perhaps we just need to move the threshold low, and we have better options to catch these patients. I have a dedicated talk on urinary sediment microscopy tomorrow, but this is just to bring this concept in HRS. I show you then the criteria. There's not much mention of this. And this is a study that Andrew Allegretti in Mass General in Boston reported in 2015. Essentially, the question was, if you were to take a diagnosis by the ICA criteria and you add the urine microscopy, how often would you change your diagnosis from HRS to ATN? And essentially, in his study, it happened 22% of the cases. There were reclassification based on the presence of granular casts. So we tried to replicate this study. This is work by Vipin Varghese, a former resident with us at Ochsner. And we were a little bit more stringent. Okay, we wanted to say patients that have ICA criteria plus the urinary sodium was less than 20. So this was not in the criteria. So we were actually more rigorous And then in those cases, how often sediment would change the diagnosis. And you can see here that essentially replicated Allegretti's study by 23% of the time. So essentially, you can tell that about a quarter of the times, the sediment may disclose ATN that the criteria didn't. But it's not as straightforward to look at urine in the context of cirrhosis when the patients have elevated serum bilirubin because it adds pigmentation. We'll discuss briefly tomorrow about this renal tool epithelial cell cast that we often see in this setting and the crystals that can be present. So it requires an extra care, be extra careful when we are under the microscope in those patients. So let's come back to this patient. This patient, remember, had arrived with no history of bone depletion, had an O2 sat of 94% already, 2+ edema. But it's still that the patient received albumin, nadolol was discontinued, and that was probably a reasonable measure since blood pressure was starting to drop a little bit and beta blockers may precipitate HRS. So a patient at this time was started on mydrin and octreotide. And this is what happened to this patient throughout the first 4 days of hospitalization. On the top graph, you have the mean arterial pressure that started about 70 and remained around 70 throughout the 5 days. And the serum creatinine progressed from about 2.4 all the way to 4.2 with no improvement in urine output of about 700 mLs a day. So at this point, we're facing with a patient who's not responding to the intervention. So what are the options for treatment of HRS? We have to talk about vasoconstrictor therapy. And these are the 3 options that we're going to discuss today. Mydrin and octreotide, terlipressin, norepinephrine. They're not the only ones, but the ones that we have more data. So starting with this landmark paper by Paulo Angeli, 1999 Hepatology, that defined the use of mydrin and octreotide. And this study, incredibly, is very small. 8 patients were treated with low-dose dopamine and 5 were treated with mydrin and octreotide. And the patients with this combination did very well. Much more improvement in creatinine by day 5, as you can see in the bar graph. But the design of the study required a patient who received mydrin and octreotide where the dose was titrated to reach an increasing map of 50 milliliters of mercury from baseline, whereas the dopamine patients were intentionally treated not to touch the blood pressure. That was the low dose renal dose dopamine of those days. So you can see at the end of the study, you had a group that was treated with a blood pressure rising 60 milliliters of mercury versus no blood pressure control. So was it actually a study comparing 2 drugs or comparing 2 goals of blood pressure? We'll come back to mydrin in a little bit, but let me just tell you that you're not going to find any type of placebo control study in the literature because it has not been done. What about terlipressin? Terlipressin has become FDA approved in North America not too long ago, so it's important to share the confirmed trial that was published in New England Journal of Medicine. Florence Wong, the first author, we at Ochsner were one of the sites. We enrolled 9 patients. The 2-to-1 randomization of terlipressin versus placebo, 90-day follow-up. The primary endpoint was the incidence of verified HRS reversal, which was defined if 2 consecutive creatinine values less than 1.5 for at least 2 hours apart, allowed without dialysis for at least 10 days. And this was the results at 29% versus 16% incidence of HRS reversal, which led to the approval of this drug in North America. We recently looked at need for dialysis, and again, this required a pooled analysis of the 3 trials, 2 that were done before confirmed, which were the reverse and the OTO41, because none of these studies were independently powered for RRT as an outcome. And we observed that when you pull the 3 trials, there was a reduction in RT among survivors. Important to mention that caveat, because if you have death, a competing event, you have transplantation, a competing event, it is not a clean analysis to look at RT in this context. Nevertheless, we did see that there was a reduction in need for RT in these patients, even post-transplantation. But there's not all good colors in this terlipressin story. When this trial was published, one of the things that was caught was that there was an increased incidence of respiratory failure for the patients who were treated with terlipressin and albumin compared to the placebo albumin. So again, there was some discussion that it was something about the albumin that was given prior to the trial, but when you actually look at the analysis, it's really hard to argue that terlipressin did play a role. We have not seen this phenomenon occur with norepinephrine or mitomyclopramide, so it appears to be a case. So it's important to be cautious and to avoid the use of terlipressin in patients that are hypoxic or have some degree of risk for a respiratory failure. What about norepinephrine, a good old pressor that we use for shock in the ICU? So we have actually some studies, about 6 or 7 in the literature. I'm going to share with you a couple from India that have compared norepinephrine versus terlipressin. And actually the results are quite clear, very, very much the same. Identical results in terms of reversal of HRS, provided that the mean arterial pressure increases to the same degree. That was done by Sharma, and the same results by Singh. So not much of a difference when you look at scheduled doses of terlipressin versus norepinephrine. What about comparison against mitomyclopramide? There are a few studies that have some limitations, but within those contexts, we have a paper from Egypt by El Dessouky that showed norepinephrine being superior than mitomyclopramide, and they studied mitomyclopramide didn't rise blood pressure. And also terlipressin was superior to mitomyclopramide because in the study by Cavallini, mitomyclopramide didn't raise blood pressure either. So it seems to be that we kind of come up with the same observation that the drugs that raise blood pressure better do better. Now, coming back to this case, remember we have treated this patient so far with albumin, mitomyclopramide, but things are not going well. Creatinine keeps rising. We got consulted at this time. We were aware of this medical literature. So at this time, the patient was transferred to the ICU for initiation of intravenous norepinephrine. It was also noted that the patient had developed worsening ascites, and that was a concern. And we were also asked, should we be okay with doing paracentesis, or should we not do that to avoid activation of the renin-angiotensin system and further derangement of the AKI? In 2011, worked with a biostatistician, Paul Neitert, and looked at this meta-analysis of clinical trials. The question was, let's pull all the trials that have tested any vasoconstrictor in the context of HRS and see the relationship between mean arterial pressure and improvement in kidney function, whether it was terlipressin, norepinephrine, vasopressin, etc. And the results were very clear. You can see in this graph on the y-axis going up is worsening of creatinine, going down will be improvement in creatinine. And on the x-axis going to the left is drop in blood pressure, going to the right is increase in blood pressure. As you can see, the more the blood pressure increases, the more the creatinine goes down. Very clear across the board. And this is a 501 patient data in 21 publications. It was also interesting to look at a baseline map within these trials, and it was actually 75 to 76. And this is something that remains underappreciated, that it's expected that to call HRS, you need to have a map of 60 or 65. If it's 75, that looks good, but it's not really good for this population. So this is not a shock disease state. This is a different disease state. And so we took this observation from a meta-analysis and tried to say, okay, let's get original data to see if it matches this meta-analysis. So this is at the Medical University of South Carolina, 2015, looking at patients that were treated with mitomyclopramide. The bar graphs show different quartiles of blood pressure rise going from the left to the right, more rise in blood pressure, and going above 0 is worsening in creatinine, below 0, improvement in creatinine. Once again, you see the same type of relationship. And we saw the same relationship with norepinephrine-treated patients, where the greater the rise in blood pressure, the greater improvement in kidney function. So we're pretty confident that this was a very strong indicator. And when we conducted multivariate regression analysis, The MEL score wasn't a factor, the baseline MAP or baseline creatinine. The only factor that played a role was the increasing MAP. And then when we moved to Ochsner in 2016, we wanted to continue looking at this question and try to get more granular data. Okay, how high does the MAP need to go up? There were some recommendations about 5, 10, 15 millimeters of mercury. And so for this, we collected data from both centers. 70 patients went into this paper that we got it published at Kidney 360. And essentially it looked like, looking at this sort of ANOVA for trend, that the graded increase in blood pressure greater than 15, it seemed to be really associated with graded reductions in creatinine, as you can see in this graph. And again, we conducted a multivariate logistic regression, and the strongest factor associated with improvement was actually norepinephrine versus mitodenoctotide. And the reason is because you were more successful raising blood pressure with norepinephrine, and the change in MAP was also significant and associated with improvement in creatinine. Now, one of the things that I love to discuss is, okay, we're talking about a disease state that is characterized by vasoconstriction of the renal vessels that leads to hypoperfusion, and then we're coming in with a vasoconstrictor to correct it. So it's a little bit counterintuitive. So let me walk you through what we think is going on. You have here on the left-hand side a renal autoregulatory curve. Y-axis is renal blood flow. X-axis is mean arterial pressure. We have the ability to regulate our blood pressure, our renal blood flow within a certain range. If the blood pressure goes up and down within normal limits, we don't really lose GFR or blood flow. We maintain because we have renin-angiotensin and systemic catecholamines that allow us to regulate that. What happens in cirrhosis is that you have this activation of the RAS and sympathetic nervous system that kind of lock our arterioles and impair our ability to autoregulate. So all of a sudden you have a reduction in renal blood flow associated with this reduction of mean pressure and sort of a linearization of this curve. So when we bring back a vasoconstrictor, what we're going to try to do is take advantage of this linearized curve and try to push the patient up into this curve by pushing them up and restoring blood flow. Of course, we're not going to normalize the patient, but essentially bringing that back up. By doing that, the effective arterial blood volume is restored, and the original stimuli to release catecholamines and angiotensin actually gets reset. And it's been shown that if you look at levels of renal activity or norepinephrine several days after the vasoconstrictor has been started, those levels come down. So that appears to be the result of restoration of blood pressure. Now, the other element of this that was present in this patient was that had this worsening ascites. The question was, should we go ahead and do paracentesis? So this is an important paper from Pierre Ginés in Barcelona. Once again, a group has made significant contributions in this field. 105 patients went onto this study. But before we look at that study, just want to remind you that when you try to search for evidence supporting the fact that albumin-treated paracentesis triggers HRS, you won't find that evidence. I've done numerous PubMed searches over the years, and it's just not there. Even though you would read that statement even in textbooks, they say paracentesis triggers HRS. So this study by Pierre Ginés, they look at AKI after paracentesis, and patients who didn't receive albumin, yeah, it was quite significant, 11%, but it was 0 for those who did receive albumin. So it kind of raises the question in the context of in the way we practice today, that we give albumin for patients who are have more than 4 to 5 liters removed, AKI seems to be unlikely to occur. And we also start to notice evidence that go in the opposite direction. The paracentesis may actually be beneficial. This is a study from Thomas Umgelter in Germany, 2008. Patients with cirrhosis and AKI in the ICU. First of all, they looked at intra-abdominal pressure by looking at blood pressure, and they showed that paracentesis leads to a reduction in intra-abdominal pressure from 22 to 9 millimeters of mercury. But more importantly, they looked at creatinine clearance. They performed 4-hour creatinine clearance. It showed some improvement in a short term of these patients, that paracentesis were actually beneficial. And now more recently, Harris Thitapathy and Andrew Allegretti, once again in Mass General, wanted to ask this question a little bit more systematically, and they look at patients that were hospitalized at their center, and they underwent paracentesis. And they essentially wanted to look at creatinine changes within 48 hours post-paracentesis. How often did AKI occur? And it was 5%. And how often creatinine got better? 10%. So they were more likely to improve than worsen it if you got paracentesis. And this is a final report here that I'd like to share from Portugal. 23% prevalence of acute abdominal compartment syndrome in patients with cirrhosis in the ICU. So the more we look at this, it seems like not quite evidence that paracentesis will be detrimental, maybe actually the opposite. So at this time, the patient, we decided to titrate norepinephrine to increase the MAP greater than 50 milliliters of mercury, as based on the evidence that I shared with you, and also to go ahead and allow the patient to undergo paracentesis. Here is you have the MAP increases, and as the MAP increased, the creatinine started to level off nicely here, no longer rising, and the urine output increased from about 700 plus to about 1,500. So we doubled the urine output. So we're quite satisfied. We thought that the ICU team was going to be very happy with us. Paracentesis was performed, but of course that's not the case. The ICU is usually not fully happy. So we got the phone call, and the ICU was saying, well, creatinine is coming down, but we don't care. Patient, I'm concerned about volume. This patient is hypoxic. I want you to do dialysis. I'm sure you'll face that question at some point. It was like, okay, what is exactly the issue here? The issue is that the kidney function is improving, but the volume is not improving to the extent that we expected, and that's still concerning. So are patients with cirrhosis and AKI at a risk of fluid overload that is unique? So we have to start by portal pulmonary hypertension. This is an entity that is well described. There's pulmonary vascular remodeling associated with portal hypertension. And we have some epidemiological data, a couple of studies, one from Romania, one from China, showing that the prevalence is not trivial. And this is why reason that patients that are in the hospital undergoing evaluation for liver transplantation, we often see them going to get a right heart cath, because they need to rule out pulmonary hypertension, not something that we do, for instance, routinely in the kidney transplantation world. We do it in liver transplantation. And we also know that this is an entity called cirrhotic cardiomyopathy. Early on in stages of HRS, we described how there's a state of high output to try to compensate for the fall in systemic vascular resistance. It's called a high output heart failure. But eventually, some conduction abnormalities ensue. That's all dysfunction can happen, and patients may develop cirrhotic cardiomyopathy. And another thing to really see is this concept of venous congestion and cirrhosis, and it kind of challenges this idea that we have to volume expand everybody that walks into the emergency room. This is a paper by Prem Kumar in India, 76 patients. They were actually undergoing right heart catheterization. And these investigators were looking at comparison of point of care ultrasound versus CVP. But that was not what I'm trying to share with you today. What I'm trying to share is whether you use IVC on the y-axis or intravenous pressure on the x-axis, it's clear that half of the patients in this cohort were congested, had numbers got greater than 12. And these were not patients in AKI. So it's really easy to assume that if you add AKI to this context, patients with cirrhosis and AKI are going to be more likely to be congested and hypovolemic. And another important aspect of this volume management in HRS and vasoconstrictor therapy is the idea that every time that you give a vasoconstrictor, whether it's norepinephrine, mitomyclopramide, or terlipressin, that you have to use albumin. And where does that come from? The data comes from Ortega in Spain. This is actually a prospective observational study of 21 patients. 8 patients got terlipressin. Only 7 of them had HRS1. The other patient had HRS type 2, which is more of a chronic version. And the patients who received the combination were 13, and only 9 of them were HRS1. This is the study. That's the quality of the study we're dealing with. And these are the results. The patients who received albumin and terlipressin, 77% of them had reversal of HRS. So it looks pretty convincing, right? 77 versus 25%. Let's look at what happened with the MAPs in this study. And it's once again, the terlipressin and albumin treated patients had an increasing MAP, and patients who got terli alone somehow, and it's not clear to me why, the MAP went down. So it's not really a study that is a slam dunk, and I would argue that there isn't a trial in the literature that in the context of a properly treated HRS patient with a proper increasing MAP, the addition of albumin provided benefit to the vasoconstrictor alone. So we went back to this patient. We discussed this case with the ICU team, and we agreed that albumin should be stopped. The patient was hypovolemic. And we went further and added a diuretic, Lasix intravenously. And again, using the diuretics in this context has been a little bit difficult to introduce because, once again, you open a textbook and you will read the diuretics precipitate HRS. They demand us to stop diuretics upon the patient's arrival to the emergency room. So how on earth we're going to bring back a diuretic in a patient that we're thinking that diuretics are the potential cause? Look at the urine output of this patient and look at what happened to the creatinine. It continued to nicely come down on that purple line. So that was pretty exciting. And the rationale for us at the time that if you were to restore perfusion by increasing the MAP, it's okay to enable forced natriuresis. We do this all the time in patients with ischemic ATM, right? We diurese with their volume overloaded. Why not? Now, this was one case, and of course, we don't want to practice anecdotal-based medicine. We wanted to say, okay, let's try to continue applying this rationale since it was safe and successful. A lot of these patients had portal pulmonary hypertension, very congested. They were transferred to Ochsner after 5 days and announced in hospital, receiving so much albumin that at the time they arrived to us, the serum albumin was 4.5 or 5 grams per deciliter. So we wanted to kind of be more proactive about utilization of diuretics. So we took 44 patients who received norepinephrine for AKI and had a MAP rise of at least 5 millimeters of mercury. And 20 of them were actually also treated with loop diuretics at some point during the course of therapy. And we wanted to look at 2 things. We wanted to see how successful we were increasing urine output and how safe was it. Because if we increase urine output and the creatinine starts going up, then that's not necessarily good. We're maybe causing a problem. So this is the baseline characteristics. A patient had a creatinine of 3.8. These are not trivial AKIs. Male scores of 32, urine output at baseline of 275 mLs per day, and and the dose that we used was high, 160 milligrams per dose every 12 to 8 hours in average. And these were the results. First of all, looking at urine output, the rat box whisker plot here shows before any treatment, pre-naive, the urine output was very, very low. When we added norepinephrine, the urine output nicely doubled or more, but the addition of furosemide to the norepinephrine further improved the urine output. And what happened to the creatinine or the kidney function along the way? First of all, you have worsening creatinine prior to therapy, stabilization of creatinine with norepinephrine, and further stabilization of creatinine with furosemide. So that we see no detrimental effect of diuresis. Now, one of the challenges that we have, as I show you the earlier Venn diagrams of the overlap with HRS-ATN, is sometimes we are in a situation where we think it's HRS, but we're not quite clear, maybe some ATN present, and we're sort of in this gray zone, and we're trying to see what can we do, should we treat this patient? And this is an important question because either you send the patient to the ICU, which is expensive, or you use telepresence, which is even more expensive. So we don't have really, this is not a situation, and the mitomycin doesn't work. So we really have to be careful about who to treat. So in this study of 45 patients that we have treated at Ochsner, we took patients that had HRS, that had a FeNA, and had a sediment done. For those, if you see in the right bottom corner, a sediment showing tons of muddy brown cast, cases like that, we were defined, well, this is ATN, this is not HRS, we're not going to treat these patients. But sometimes we have patients where the urine is either completely blind or it has highly cast, so clearly no ATN. But some patients, we do see a little pigmented granular cast, just like the Solomon paper manuscript in 1959. So we are not in a position, okay, we're not going to rule it out. We're just not going to treat him, okay? But there is some ATN. And as I said, patients had to be treated correctly, meaning that the MAP had to go up at least 5. You know, if you put somebody on norepinephrine and somehow the MAP doesn't change, you're not really treating that patient. So you don't want to include those patients in this study because your biomarker is not going to be fairly assessed. So let me walk you through this data here. On the y-axis, you have the delta MAP in the first 72 hours. The higher the MAP rise. And on the x-axis, you have the delta creatinine. Going to the left of 0 is improvement in creatinine. Going to the right of 0 is worsening in creatinine. The size of the data points is related to the degree of the FeNA. Remember, every patient here had a less than 1%. Otherwise, we would not have been considered HRS. We wanted to see how low was low, right? So the tiny dots had a FeNA between 0.05 and 0.29, and then the middle size 0.3 to 0.49, et cetera, going out to the larger ones, which had a FeNA of 0.7 to 0.89. And then the colored dots are those who the sediment had a little bit of ATI, and the clear circles had no ATI. So you can see here that it's not a clean distribution of data, right? There's not absolutely say, okay, this is a classic cluster of patients that all get better. But we kind of get to see a little bit of flavor that, that if you were to sort of highlight the patients who had primarily a very low FeNA and no ATN, they tend to be clustered on the left-hand side. So again, this to me shows that these are helpful tests that we have available today, but we definitely don't have a sort of a clear-cut biomarker to determine who's going to respond to vasoconstrictor therapy. Last few minutes of the talk, I'm going to talk about briefly cholemic nephropathy. It's very hard to talk about HRS and cirrhosis and not say a word about biocasts, because I always get that question at the end. And let me just start by reminding us that cholemic nephropathy or cholemic nephrosis or obstructive jaundice-induced AKI is an old disease that was described in patients that have, for instance, a cholangiocarcinoma obstructing the biliary tree, and they showed in the kidney tissue they had this tubular damage associated with that. But more recently, having some controversy that is this really one of the mechanisms for AKI and cirrhosis. So we have evidence that shows that that's probably not the case. I show you early papers in 1950s, 1970s, where the kidney tissue in autopsies have been shown to be completely normal. So that doesn't really fit into that. We also have the data from Hani Wadeh in Jacksonville, Florida, who has biopsy-proven cases of HRS. So that doesn't really support the biocast story. But of course, we have biocast papers that challenge that. They're reported by Tony Chan in 2013. A couple from India and Canada show that, you know, if you look at tissue carefully, you will see it in patients that have these biocasts. And then from the urine microscopy perspective, we have this this renal tubular epithelial cell cast, and when you see tubular epithelial cells sloughed off, the more higher the bilirubin, the more we see them. It's hard to argue that these tubules are not damaged. But this report by Jose Antonio Poloni in Brazil showed that in patients that have high bili, in blue are patients that had AKI, and in purple had no AKI. So what he showed us doesn't really matter if you have AKI or not. High bili will lead to this cast. So it brings you to this idea that might be some subclinical tubular injury present, but it doesn't mean that's driving the drop in GFR. And finally, from the experimental side, we have a study here from SAI showing that this bile acid agonist is actually beneficial to the renal perfusion in this model of AKI. But we also have models to show that it could be bile acid could cause damage. In a bile acid receptor knockout mouse in Austria by Fickert, showed that less damage was found in these animals that were subjected to common bile duct ligation model. And more recently, out of Germany by Gallup and collaborators, using a bile acid transporter inhibitor, they showed reduction in tubular casts that are shown in green compared to the animals in purple who show no cast. So there's something there. So if a patient has a bilirubin of 45 and the urinary sodium is elevated and there's cast in the urine, it's reasonable to conclude that some degree of tubulopathy can be present, but I still think that the hemodynamic derangements continues to be the primary process here. And finally, we have to always remember that at the end of the day, patients with cirrhosis are at risk of other things, such as acute glomerulonephritis. This is a patient that has alcoholic cirrhosis. Hepatitis C is no longer the primary cause of cirrhosis, but we still see some hepatitis C as this patient presented with AKI with hematuria, leukocyturia, proteinuria, and red blood cell casts in the urine. It was obvious that this is not a patient with HRS. Patient ended up having a RNA viral copies present, low complement C4, and the kidney biopsy showed the proliferative endocapillary proliferation consistent with FCGN. So this is something that we also have to keep in mind because it's a completely different management for those patients. So to conclude here, I'd like to bring back this sort of a challenge of the traditional conventional Venn diagram and invite you to have this sort of a more comprehensive approach of AKI and cirrhosis. And in terms of treatment, a vasoconstrictor therapy aimed to a target rise of MAP of 15 milliliters of mercury is the primary approach. Of course, ultimately, liver transplantation is the curative therapy. But in terms of the medical management, as we do, norepinephrine, the primary option, especially in the ICU, telepressin, we can use it on the floor, but not superior to telepressin in the ICU. And again, the introduction of diuretics as opposed to being a proalbumin and managing volumes in patients that are treated with vasoconstrictors should be considered. And this is just to acknowledge the team at Ochsner, some of our collaborators, and the Harmony Consortium. And yeah, that's all I have. Thank you very much for your attention.
Thanks, JC. So if people have questions from the online, please feel free to, I'll just stop sharing. Okay. Please raise your hand and we can call upon you. I was just checking and it looks like terlipressin is unfortunately still not licensed in Canada. So we are still behind and again, it's very expensive. So we don't know when we'll be able to afford it. But your data on the map is very interesting that you've been showing. So in a situation where we don't have terlipressin, can we just ramp up the midodrine octreotide to achieve a MAP increase? Does that ever work, or should we consider transferring to ICU and getting them norepi?
Yeah, that's, we have used as much as 15 milligrams every 6 hours. And octreotide could also be titrated up to 200 micrograms. Typically, I started with 100. You can actually titrate with 200 Q8 hours. So you can do that. And I haven't really been very successful achieving the increases in MAP that are going to change the trajectory of the creatinine. I'm not aware of any kind of systematic study that have tested supra-therapeutic doses of midodrine. What about we go to 20 milligrams every 4 hours? I mean, it's potential. We don't have data, and midodrine is relatively safe. However, we have a couple of cases where patients develop urinary retention with midodrine. We have some patients with hypoglycemia with octreotide. But I think this is an area where we need more data in terms of oral agents. There's a new FDA-approved drug for Parkinson, droxidopa. I don't know if it have been available for you. It's available for us as an outpatient. I'm actually working with our pharmacy committee to get in an inpatient formulary because the combination of droxidopa is a norepinephrine precursor. So your combination of droxidopa, midodrine, and octreotide, can you actually get a little bit further increase in MAP potentially? But in terms of what we have data available, it really norepinephrine is the drug of choice. And you may ask, well, what about phenylephrine or vasopressin? I mean, technically, any of those pressors could work. And because there hasn't been any type of comparative study between them, it's just that people started testing norepinephrine, the trials kept being replicated. And that ends up being forcing us to be sort of judicious, right? Because we're not going to call our SU guys to transfer every AKI with cirrhosis when we think it may be HRS. And that's the challenge, that we kind of try to pick our battles and say, all right, this is a patient that not only the likelihood of being HRS is high enough, let's also, remember these patients, if not, they're not going to get a liver transplantation. Some of them may go into the hospice route, and those elements come into the decision about how aggressive we're going to be.
Yeah.
Yes, Brendan.
Question about hyponatremia. So in the old international ascites club criteria, hyponatremia was kind of a supportive feature, and that seems to have disappeared. Clinically, I've always found it kind of helpful in someone presenting AKI with cirrhosis. If they've only got sodium of 138, 137, it's almost never plays out as hepatorenal syndrome. Have you ever looked at it kind of analogous to how you've looked with fractional excretion of sodium, the degree of hyponatremia on presentation as a predictor as to what course you're going to take, more of a hepatorenal or an ATN course?
So yeah, great. Thanks for the question. And I agree with you 100% that the old definition had the hyponatremia, and the phenotype of these patients almost always includes hyponatremia. The mean sodium value of almost all these trials of sodium is about 130, 128. In our study, it was about 133, 132. We did look at hyponatremia as a determinant of vasoconstrictor response, and we didn't see a signal. But remember that these are all patients that we chose to be the classic HRS so that it was worth calling the ICU and transfer them. So the sort of the distribution of the high sodium data was between 128 and 134. So it's so tight that it was not surprising to me that we didn't see any kind of separation. But if you were to take everybody, I would agree with you that, yeah, if you have a sodium of 137, you're probably going to find some other element on that case that points you away from HRS, whether the urinary sodium was elevated, whether the MAP was 89 to begin with. So you start to to look in a different direction. So I think what you are mentioning is something very important, which is the phenotype of the HRS patient, which was in the original definition in the late 90s and is no longer present. And we're actually trying to get it back, but it hasn't been a successful battle yet.
Oh, Peter.
Hi, I guess I like your focus on the extra low FENA, and I never really got there was a higher cutoff because, of course, most of our FENA every day is about 0.6. So I don't know. I always thought a high FENA was a marker of ATN if it's above 1 or 2, rather than the other way around. But I guess clearly the focus is on volume assessment. And I don't think any of us routinely do ultrasound for IVC diameter to see where your volume is. So we're sort of stuck, aren't we? Because I must admit, most of the time looking at people, I don't know if they're volume overloaded or not. And the assumption is that they probably are underloaded, and I've always been in the school of give them lots of saline and see if it gets better. So really, if you're not doing IVC ultrasound, what do you do?
Yeah, no, that's a fair question. First of all, we try to be as good as we can be with our clinical skills. Before that, you examine the patient, you look at the history, right? If you have somebody that comes in and has been laxatives were added or spironolactone was added to a loop diuretic, decreased POE intake, you have a history, and we know in medicine that that's like 75% of the story, right? And I think we practice such a sort of a iPad virtual medicine these days that sometimes I encounter cases where the history is that the patient hasn't been urinating, is being progressively swelling at home. How are you going to blame volume depletion and give more albumin to somebody who has gained weight at home, right? So those are the elements that I'm not telling you in particular, but this is things that our trainees miss. So what we do is, in our center, we do have a team to do point-of-care ultrasound, but before we had it, I was ordering echoes in the hospital. But I know if here in Canada, that would be much more problematic to just freely order echoes. But I would order an echo and I say attention to the CVP, and the report will give me some idea of that. But short of that, it's just history and physical, and just to be aware that is not as trivial as, okay, let's just give volume and see what happens, because the data shows that some of those patients could actually end up having pulmonary edema. But at the end of the day, I agree with you. I wish I could tell you that I am always certain about the volume status of my patient with cirrhosis, but I think sometimes the patients have this tense ascites, very edematous, it's very clear, or they have some growing hydrothorax in the chest x-ray. And there are some red flags that more albumin is probably not going to be the way to go.
So on that same note, if I can ask about the albumin, I had a patient last week where we kept giving on albumin and it went up to 4.5 or something like that. Should we stop albumin based on the assessment of volume, or should we use a serum albumin, or is there a certain amount of albumin? Because the concern, of course, is the fluid overload.
Yeah, no, I think both. I think both parameters are to be watched. If albumin is already 3.6, 3.7, I'm not convinced that giving or continue giving albumin is of any benefit. I cannot tell you, I don't have any data that say this is the cutoff, that further albumin doesn't provide substantial volume expansion. My intuition tells me that if you get closer to 3.4, 3.5, you've probably done good enough that shouldn't require more albumin, but also clinical science, of course. But for us, since we are a high volume liver transplant referral center, we get patients from outside hospitals that were treated for 5 days already, and they arrive with normal albumins to us. So we had to stop it. We don't give any more. It's just too much. Yeah, it's been interesting to watch you look at the baseline serum albumin of the 3 HRS trials in North America, and the baseline albumin on the first trial was 3, on the second trial was 3.3, and it was 3.7 in confirm.
Yeah. And I think in confirm they needed to have had albumin, so much of albumin as an eligibility criteria. Right?
Yeah, you would be with the sponsor and on the phone, and it was essentially, have you challenged the patient with the albumin? It was sort of a not quite a hardcore inclusion criterion, but it was highly encouraged to go through that. Yeah.
That was great. So that was going to be one of my questions related to that. Is there a linear relationship between the serum albumin and the response to albumin in terms of blood pressure? These patients are.
I don't know.
Yeah.
I don't know that. I have not looked at that. We have to. Those are probably all studies that they were looking at albumin as an expander. The study that I showed, I didn't show one, but there's another earlier study that compares saline with albumin in patients that have portal hypertension. But I don't recall that they characterize the data based on the degree of hypoalbuminemia, which is you're asking. Yeah, great question.
Dan?
Do you ever try to dose albumin per kilo? So for a little person, you give much less than for a larger individual, or do you give a certain standard?
Yeah, I'm doing standard. So it's typically 1 gram per kilogram on the first 24 hours, followed by 20 to 25 grams per day. That's kind of the general recommendation, which would require to give 25 grams Q8 or Q6 for the first day, followed by only 1 dose a day. But I can tell you that I tailor those decisions based on the case. So if I use albumin for a patient that is clearly bone depleted, I'm going to be more aggressive. Sometimes I use albumin to the treatment of hyponatremia. Whereas in the context of HRS, I become less of an albumin user because I see and become volume overloaded so often that I use less of a dose. But those are the numbers that most people manage. Yeah. And it's 25% albumin. It's actually, there are some small scale studies showing that it's a little bit better expander than the 5% albumin, and you have to give less volume also. So it's recommended to do that. I'm not sure what the difference in price is between 5 and 25%. Yes.
That was a really great talk. Thank you. I'm wondering, it sounds like your center might be different in terms of the timing of when you get involved. So I think in a lot of cases, the patient will have already been on albumin, octreotide, midodrine, and now the creatinine's really bad. And we got a call, sort of 1-800 call, you know.
Yes.
So it sounds like the culture is a bit different. So at what time in the time course do you actually get involved? Like, would it be sort of an AKI 2 sort of situation? It sounds like maybe the threshold is a lot lower to get you involved. I guess because, you know, you can intervene more and figure out the story more if you're involved.
Yeah, no. I wish I could say that we're always asked to intervene earlier. I think in our center, because I have an IRB protocol approved for sort of a prospective data collection, and I have sort of an alarm system that informs me of patients that are admitted with a cancer. So I started watching the patient and on the chart and let my team know. So sometimes we ended up being consulted because of that reason. But outside of those cases, we do get consulted just like you late when the patients have failed midodrine and octreotide for several days. And as any form of AKI, the earlier you intervene, the greater the likelihood of response. When you look at, for instance, data with terlipressin or epinephrine, the creatinine is above 5, above 6, above 7, your chances of reversal are very, very slim. So it is true. You are true that you catch it early.
Because from the data you showed today, it would suggest that not only is the mitogen triazide probably not going to work, but the fact that you sit on it for a few days and hoping that things change, maybe you're delaying a more effective therapy.
100%. I agree. I agree with you. Yes.
That's an important teaching point for us.
I see you.
Yeah.
Yeah.
I see you forever.
Yes.
One last question, terlipressin and respiratory failure, right? So this is one of the knocks against it. Do we know the mechanism?
You know, there's some animal studies showing that vasopressin can cause have V1 receptors in lung and cause some of the pulmonary hemodynamics leading to pulmonary edema. I have actually had a patient that we treated with terlipressin and developed flash pulmonary edema overnight. I could not believe it. So this is real. This is not, when the study came out, I was on the skeptical side because nothing was mentioned in the O2041 trial and reverse trial. You got all this body of literature from Europe and Asia showing nothing about this, and all of a sudden you see it, right? But this particular patient, for instance, had no obvious systolic or diastolic dysfunction on an echocardiogram prior to terlipressin, because we order now that as a cautionary step. Patient was not on oxygen, had a clear chest X-ray, had received albumin, but not a colossal amount of albumin, and developed this massive pulmonary edema. So we had to stop the drug and switch terlipressin to norepinephrine. So yeah, it is not fully elucidated, but there appears to be some effect. The other advantage of norepinephrine is norepinephrine has an inotropic effect. So maybe that protects the patients from developing this as well. So.
Thank you.
Thank you.
Okay, hey, yeah, so